issue. It's not our intent necessarily to change your mind, but rather to provide you with the answers that will help you make an informed decision at the ballot box. It is our hope that everyone at this meeting will be treated with respect and courtesy and conduct themselves in a friendly and civil manner. To that end, following our presentation, when we open the meeting for questions from the floor, we are going to ask that you limit yourself to one question each time you are recognized. Once your question has been answered or addressed, we will allow then someone else the opportunity to ask a question. We will continue in that manner until either all questions have been answered or we reach the end of our allotted time as published in the announcement. If at the end of this time you have unanswered questions, please feel free to visit with one or more of us before leaving. We will make every effort to stay on the topic of the proposed sales tax. Should we stray from the topic, it is my job to get us back on track. As an example, all of us have, at some point in our lives, had an unsatisfactory experience with a business. Our forum tonight is not to address those or similar off-topic issues. And with that, I'll introduce you to Curtis.
Thank you, Frank. All right. Well, thank you, everybody. Us Marysville folk made the trip over to Axtell and have a town hall, so I'm happy to be here and happy to be in the community of Axtell with our clinic that we opened up several months ago. I do think it's making a nice impact here for the community, and it's a good way to partner with a community group that wanted to create, a fitness center, and we're happy to make it a clinic as well. So I think hopefully the folks here in Axtell appreciate having a clinic in their hometown. Frank said, my name is Curtis Hawkinson. Just started my 18th year here at CMH, and it's been a great thing for me and my family to be here and lead our rural hospital. As Frank alluded to, the blue signs that are on our highways as people come to town, these are kind of important things. I really, always kind of notice them when I go through other rural towns that they have one of these signs in their community, and that they have a hospital here that's open 24/7. We've been fortunate enough to be open nonstop since 1958. So if you think about that, the hospital lights have never shut off for our community and our area that we serve. So we're proud to have that H, and it stands for something, and it means that we have a hospital in our community. So we should be proud of that. Tonight, I'd really like to talk a little bit about rural health care in general, kind of take a little broader perspective of rural health care in our country. Talk a little bit about state rural health care, and then we'll talk about kind of the local challenges that we have. Oftentimes in rural America, we do have our challenges. We do have workforce shortages. There's a shortage of workers in many of our licensed personnel, and pretty much in every department that we have in our hospital. It seems like our managers are always struggling with retention and finding new staff members once they retire or move on. It's just a constant challenge that we have. We also take care of a lot of vulnerable populations. I'll show you some graphs about, we take care of a lot of the people that are 65 plus, are on Medicare, people that are on Medicaid, people that are veterans. So we take care of a lot of those populations. Our county, we do have some poverty in our county. We, as a county, we do participate in some of the governmental programs because our average income is lower than the state average in our our county compared to what the state average is, and so that does qualify us for some health professional shortage areas with rural government rural health care programs. That helps. And also geography. We are probably not as isolated as some rural hospitals in our nation. We have Manhattan, Beatrice to the north, and tertiary hospitals in Lincoln. So we're fortunate. We're not all that close, but still, geography does play a part. Also, the uninsured in our county, we have about a 10% uninsured population that people do not have health insurance. Invariably, they do come in and need health care, and that's just the fact of life. Not everybody has health insurance. Not every job that people have in our county provides health insurance. A lot of small businesses or in the ag economy and the ag, do not provide health insurance necessarily for the jobs that they have. And that's just the way it is. And like I said, we have about 10% uninsured in our county. Also, just kind of some other data points on some of the rural challenges that we have in our populations. Incidence of heart disease in small town America is 56% higher than you'll see in your urban counterparts. We do have higher respiratory disease. We have more unintentional accidental injuries, and obviously we have a lot more highways that are in our county. The farm, people on ATVs and those kinds of things. Cancer fatalities declined nationwide. However, they fell slower, 60% slower than rural America. And there's also a widening gap of life expectancy between your urban dwellers and rural dwellers as well. As I was kind of talking about in the rural space, you'll see our population will be 69% higher in rural communities than you see in your urban counterparts. So we take care of more of the Medicare beneficiaries. Diabetes is the higher prevalence in rural America. Your veterans, we take a higher percentage of veterans live in rural America. Access to primary care is lower in rural areas, but I don't think that really relates to us in Marshall County. I think we have very good access to primary care. But generally, talking about the rural populations, they have less access to primary care. And obviously, this is probably true in our local area as well, is that we have lower access to mental health. Kind of a national map of Medicare patients with 6 or more chronic conditions. Obviously the darker shade areas is areas that have more than 6 or more, but we're right here, and actually we do have a higher shade than some of our counterparts on each side of us, Washington and Omaha County, with people with more chronic conditions as part of our population. Kind of what we're seeing in rural America right now is less hospitals are doing OB services. And, today almost 60% of the rural counties are without hospital-based obstetrics. More than 200 maternity wards closed from 2004 to 2014. And I probably need to find another statistic there to kind of update that. But they're kind of going away. And I think, obviously it has to do with population, the number of births that you have in your facility. I think that plays a big part, whether you can continue the service. But rural areas have higher rates of chronic conditions that make pregnancy more challenging. Higher rates of childbirth-related hemorrhages and higher rates of maternal and infant deaths are all kind of part of the rural makeup. Half of the women that live in rural America live more than the recommended 30 minutes from a hospital offering maternity services. These are just some graphs here from 2010 to 22. You can see the percentage decline with county that had hospital-based obstetrics care. And even in the metropolitan, the micropolitans, communities such as maybe the size of Beatrice and those kinds of communities, they've even lost their OB programs in some sense along with the rural cities that have lost their obstetrics care. Actually, it's kind of just more of the same. 41% of all rural hospitals operating have eliminated this service since 2001, and less than half the nation's rural hospitals provide OB today. Just recently, Falls City, Nebraska, I think for the last couple of years, have given up their OB program, as have Fairbury, too, in the last several years have given up their OB programs. When you give it up, obviously it's more added time to get to those OB providers. 30 minutes is recommended, but now we're getting obviously further away from that, and it just could have some bad outcomes because of that. Also, what we're seeing in rural America, we've had some hospital rural closures. We've had 149 rural hospitals that closed since 2010, and that, provides, a whole host of issues of lack of access to care, economic engine for the community. It's been documented, and I think recently WIBW had come out with a story that many of the hospitals in Kansas are operating negatively, in negative margins, and that just seems to be the kind of the way things have been going. Reasons for closures, obviously, reimbursement is the big thing, in addition to maybe your area is losing population. That happens in many of the rural areas. Marshall County, we've been fairly flat, but we're not growing. We're actually losing population if you look for the last 20 years. It hasn't been dramatic, but at the same time, we've seen our enrollments in schools go down. I think we're down 9. Did I read that right in the Advocate last week? That I think we're down 9 from last year, total of students in our schools. Sequestration, that's, we're supposed to get 101% of our cost for the Medicare program. Since sequestration, they wipe off 2%, so you get 98% or 99% of your cost now. Low volume, as I said before, many hospitals struggle with the volume based on population. And then also, the changing over the last, I would say, 10 to 15 years, we're seeing a lot higher deductibles. It used to be $1,500. Well, when I first got in the job market in 1992, I think we had a $250 deductible when I first started on the medical center. And I don't know why I remember it, but the cost of that single policy was like $175 for the hospital, $175. Now I think we're at almost 1,000 for a single policy, or 800.
It's about 800.
Yeah. And that's with 35.
And of course, we'll get a new quote here next week from
And so, as people, have higher deductibles and being able to pay off those deductibles, and hence I think we've also seen an increase in our accounts receivable as well. Just kind of a chart here of hospitals with their negative operating margins in many of the states, rural states, in addition to Kansas. Kansas somehow leads the way in the nation of their rural hospitals operating with negative margins. Kind of some up-to-date information. I found an article, 8 more closures in 2023. They found that 700 hospitals are at risk of closing. Kansas has 62 of them. 360 rural hospitals are immediate risk for closing. Kansas has 31 of those. And 8 Kansas hospitals have closed since 2015. 8 hospitals have closed since 2015. And also bankruptcies of all-time high. And it creates a lot of problems in a lot of different areas when your community does no longer have healthcare access. Just kind of illustrates our uncompensated care over the last 5 years here since 2019. And that's just, 2019, And uncompensated care is two buckets. It's our bucket of charity care, people that apply for charity care, so we can kind of determine their wherewithal, financial wherewithal, and then also the bad debt, people that do not come in and set up a payment plan or try to make their payments or pay off their bills, and so hence they end up in collections. And so that's when we write that off, then it becomes uncompensated care. And as you can see, the last 3 years, about $1.5 million of our charges have been written off to that. This is illustration of the last 5 years of our net operating income, 2019, 2020, and then obviously we were in the midst of the pandemic, and we got a lot of government funding, as many counties and school districts and businesses generally either got Paycheck Protection Program for a period of time or got COVID funds, and hospitals did get, I think there were 3 tranches of COVID. I think we had one or two.
We just did one.
We did one, and it was based on need, your demonstrated need. And so on. So that's kind of the spike there in 2021 and part of 2022. And then last year, about $1.8 million deficit in 2023. Just kind of looking at Kansas here, 85% of the rural hospitals in Kansas do receive some sort of tax support, either through a mill levy or through a sales tax. Hospitals, you're either probably organized three ways in our state. There are district hospitals that have their own hospital district. Some hospitals are county hospitals organized under county commissioners, and then some hospitals are 501c3, like us, like CMH. When I did our research here, Onega was getting about $1.8 million from a tax subsidy. Clay Center receives about $600,000. I believe that's on a mill levy. Nemaha counties do have a half-cent sales tax split between Sabetha and Seneca. Washington County Hospital receives about $200,000. The half-cent sales tax is 50 cents per $100 retail purchase. The sales tax for Marysville will be made at 8.6. I'm not sure what the other municipalities have. I'm not sure if Axtell has a city sales tax in addition to the state, and then our 0.5% county tax. And looking at the tax rates in Seneca, they're at 9%, Washington 8.5%, Manhattan's at 8.95%, and Wamego was 9.25%. Kind of comparing to what Marysville would be or is. Sales taxes that rest solely with property owners and its citizens. Obviously, Highway 36 is a major thoroughfare. So anybody that stops in our community and spends any time here does help contribute towards that sales tax as well. We approximately receive about $1 million per year. And the 0.5% sales tax will come up for a vote in 5 years. And so when we did it 5 years ago, time has really went by pretty fast. It seems like it wasn't that long ago we were doing these town halls, and we're happy to do it. I think we have to continue to show the value of having a strong healthcare here locally, and continue to engage with our community folks, and hopefully answer their questions and again show the value of having a strong rural health system for our county. Just some other, obviously the last 2 years have been very inflationary, not just with our workforce competition, keeping our workforce in place, and it changed so rapidly over the last couple of years. Trying to be competitive with our wage scales. We do get a salary survey from our hospital associations every year, and there's a rural critical access hospital, kind of what different job classes are paying for, kind of based on experience and so on. And so you have to be competitive. That's just a kind of a fact of life. We, you know, in the inflationary environment, you know, we've seen many of our insurances for coverages, you know, I think the insurance market has been, every time they come, they said, well, it's really a hard market. Well, I get that. You know, more, you know, property damage from wind and hail and all those kinds of things, you know, does find its bottom line in the insurance premium at some point, and ours have gone up 20%, you know, in the last couple of years. So the rural healthcare reimbursement is changing. We're seeing a lot more Medicare Advantage plans, and they're very onerous to work with. There are a lot of pre-authorization requirements. I know I opened up a trade magazine, and this hospital system is no longer participating with United Healthcare, Aetna, and Humana. You know, but here in the rural environment, I really feel that, you know, I have to participate because our Medicare beneficiaries, a lot of them are on fixed incomes, and they're looking for a lower cost alternative. And you know, we're here to try to take care of the folks. And if they choose that United Healthcare Medicare Advantage that's going to help them give a gym membership or help them with a lower cost, I feel we need to do that for them. And because if we don't participate, then they will have to pay a higher out of pocket because we're not. If they come here to our facilities, they'll have a higher deductible, they have higher out of pocket, you know, we just have to do the best with it. And we're engaging our partners at the Hospital Association to, you know, be more of a stronger voice to pound on some of these companies to relax the pre-authorization. And they like to play, you know, armchair quarterback. It's always good to do hindsight analysis, and, you know, when the doctors try to make a decision in real time, and then, you know, a week later they said, well, that shouldn't have been an inpatient, it should have been observation. And, you know, yeah, they have the you know, the benefit of hindsight, but it's just a lot of that you're constantly battling, and it takes more people to do it. And so we've had to hire more people to do pre-authorizations and try to do our level best to try to take care of people and make sure that their insurance companies are going to pay. We've seen, you know, sizable increases in our IT, along with our EMR capital expenditures. We were hit with a ransomware attack here last October. Fortunately, you know, with our IT staff that we have, and, you know, we were down for 3 days. But some of these things, I've seen one that happened at in Topeka there at St. Francis, they were down a month. No EMR. And man, if you don't have an EMR in today's environment, you're really dead in the water. You didn't have access to schedules. They were really sunk for a period of time. But we had good backups. It took a little while to get it up and running again. We had to wipe all our servers clean and start over. And so it was a pretty intense few days there. And you know, 5 years ago, you know, you didn't have the subscriptions that you have now. Now we have like 2 firewalls, and they're all subscriptions. You have endpoint devices, you know, the virus software and all those things on your endpoint devices, and that's all, you know, Microsoft licenses, and it goes on and on and on, and you know, it never gets any less expensive. I also say too that we benchmark our operations with other critical access hospitals, and you know, and traditionally we always come out that we have less staff and doing similar work to maybe other hospitals, but we do it with less staff. And this doesn't show very well, but we are in a hospital rural network with Nebraska hospitals. This is the Heartland Health Alliance. All hospitals have their inpatient direct cost per case analysis, and this is us. We are the least expensive of all 53 rural hospitals in our group that we compared ourselves against. And so I always feel pretty good that, you know, we do try to manage costs. We try to do our level best with the folks that we have, and do similar work. And so always proud that we do our cost conscious in our organization. But, you know, I always believe we in rural America, we're used to doing more with less. need to get that off here. But we do have rural work ethic, rural ingenuity. You know, we've been through challenging times before. And, you know, that's just kind of what we do ever since, even before COVID, through COVID. That's what we do. And we've demonstrated that we've had higher quality with some of the awards that we've won. We have higher quality. We have high patient satisfaction. We're cost effective, and we use fewer resources. And we also know healthcare is about as fundamental to rural America and rural communities, and it's just as important as any other form of infrastructure, whether you have a fire department, police. We know that it's important to have healthcare. We're fortunate to have a great list of physicians here and nurse practitioners. They're all well experienced, and we're very fortunate with that. We have a great number of specialists that come to our facility. We now just got a new podiatrist that'll be starting with us now in the next month or two. So we're fortunate with that. And our plastic surgeon guy, I need to update that. He came for a while, but I don't know if he found enough business in the plastic surgery realm, so he's no longer coming. But anyway. But we've won awards, and that take in account of quality, satisfaction, and cost. We've been a top 100 hospital for the last 8 years now, and we've been a 5-star rated hospital by Medicare. I think right now we're at 4 stars, but we're always striving for higher. And kind of doing some research over the years and looking at some of the articles I found in one of our files that we had at the hospital, and Byron Guys, back when they were trying to start the hospital in 1958, said, no doubt there will be trying times, but if every person remains loyal to the hospital, it will serve as one of the greatest needs this community has ever had and always will need. Let us resolve now to ever work for the best interests of the hospital, because it belongs to everyone. And Byron Guys is quite a visionary. We do still have the Guys Weber Foundation today that contributes to a lot of things in our county, and we're very fortunate to have it. And so very poignant quote here, and I think it is great words at this time. So the ballot question will look like this. Shall a retailer's tax, sales tax, in amount of 1% be continued in Marshall County, the proceeds of which will be to support the provision of health care services by CMH. The continued collection of said sales tax shall commence April 1st, 2025 and terminate upon the first to occur. Either 5 years have elapsed since the implementation of the tax, and CMH either has merged or been purchased by another entity, and pursuant to the state statute there. I would say, though, you know, we are a nonprofit, so any dissolution has to be approved by the Kansas Attorney General. If you remember when the sisters were going to close St. Francis in Topeka, they were literally just going to close it and walk away. And then, Governor Brownback got involved and found a partner to buy receive the assets and so on. But you have to get it approved. And if there's any monies left over, what happens on nonprofits? Many times they set up a foundation for healthcare provision of services in the county. So nobody gets paid. We have corporate members. But if you're a corporate member of CMH, you get the ability to vote on board members at the annual meeting, and you get the ability to vote if there's any bylaw change. Those are the only two, rights or privilege a corporate member receives, being a member of the corporation. And I think it was set up kind of as a membership capital drive back in '58. $100 got you a corporate membership back in 1958. Well, since then, 65 years later, it's still $100. And we have, I think Pam said we have 250-ish corporate members right now. So anybody can become one. We have an annual meeting. It's the last Wednesday of April, and we have our auditors come give a financial report on the audit, and we elect board members. Those are the two main things that happen there. I give a report. The board president gives a report, and that's the annual meeting. So we are hopeful that you would support the sales tax when it comes up for the vote here in November. It says keep our pulse strong, so vote yes for community memorial health care. If we had some Axtell people here, we would tell them that we're happy to have a clinic here in Axtell, and Michelle and Linda are here 4 days a week, and to see patients in their nice new building, their fitness center. So that's the talk for this evening. I'd be happy to answer any questions that you may have. And so thank you for your time. Thank you for coming over to Axtell. I do appreciate it. I know, we all have other things we could be doing, but I'm glad that you're able to come here today.